Hello, and welcome to today's webinar, Q&A about psoriatic arthritis. My name is Bev Bromfield, and I'll be your moderator for today's presentation. Before we start, I'd like to go over a few items so you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You've joined this presentation using your computer speaker system by default. This means if you hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, select Use Telephone in the audio pane and the dial-in information will be displayed. Although we're highlighting questions received in advance of today's webinar, you'll have the opportunity to submit questions to today's presenter by typing into the questions pane on the control panel. We'll collect these and address as many as possible during Dr. Troum's session. Before I provide information about the foundation, I'd like to acknowledge and thank our sponsors, Amgen, AbbVie, Bristol-Myers Squibb, Lilly, Novartis, Pfizer, for their support of today's webinar. Since some of you may be new to the foundation, here's a little background about who we are, our mission, and what we do. The National Psoriasis Foundation launched a new strategic plan in 2019, which drives everything we do as an organization. To achieve our mission, the following goals were identified: lead collaborative and transformational research in psoriatic disease, improve health outcomes by increasing the lifespan and health of individuals living with psoriatic disease, secure resources necessary to achieve our mission-related goals. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis, moving towards a better understanding of what it means to live with psoriatic disease. If you have psoriatic disease, you can help accelerate efforts towards a cure and a greater understanding of the disease by participating in the NPF Corona National Psoriasis Patient Registry, which is the largest independent observational registry of psoriasis patients in the U.S. This registry represents a network of dermatology clinics that collect and study patient health information, allowing researchers to compare the safety and efficacy of psoriasis treatments, better understand conditions that are related to psoriasis, and explore the history of the disease. You can share your experience with researchers about what it means to live with psoriasis and psoriatic arthritis by participating in Citizen Scientist. Answer questions and view your data along with over 4,000 participants. Data is used to help researchers gain a better understanding of the disease. To learn more and participate, visit the websites listed on the screen. We continue to improve health outcomes through our Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease. The Foundation's Patient Navigation Center is available to help you find physicians, treatment information, navigate insurance issues, access support through our one-to-one program, and more. Contact us at 1-800-723-9166 or visit psoriasis.org/navigation-center. To achieve the Foundation's goals as mentioned, please support our mission through donations or by participating in virtual Team NPF events such as Stamp Out Psoriasis or Cycle events. You can learn more at psoriasis.org/donate or teamnpf.org. On behalf of the National Psoriasis Foundation, thank you for attending today's webinar and for submitting questions in advance. This webinar is for you since your questions form the basis of what Dr. Troum will discuss today. Today's questions will be broken out by categories, which Dr. Troum will mention shortly. If submitting questions today, please type your questions based on the announced topic. We'll try to address as many as possible as time allows. Now I'd like to introduce you to our speaker, rheumatologist Dr. Orrin Troum. Dr. Troum is a rheumatologist with the Doctors of St. John's Medical Group at Providence St. John's Health Center in Santa Monica, California. He is also a clinical professor of medicine and voluntary faculty member of the Division of Rheumatology at the Keck School of Medicine at University of Southern California. Dr. Troum is board certified in rheumatology and internal medicine. His clinical focus includes psoriatic arthritis, rheumatoid arthritis, osteoarthritis, gout, rotator cuff syndrome, and allied disorders. Dr. Troum pioneered the use of extremity MRI in the evaluation, clinical decision process, and outcomes in patients with inflammatory arthritis. He is immediate past president of the International Society of Musculoskeletal Imaging and Rheumatology. He has also authored numerous publications on imaging modalities in rheumatic diseases, tissue inflammation, metabolic syndrome, and more. Dr. Troum is a fellow member of the American College of Rheumatology, and a past president of the Southern California Rheumatology Society. It is my pleasure to welcome Dr. Orrin Troum, who will provide answers to your questions about psoriatic arthritis. Please welcome Dr. Troum.
Thank you very much for that kind introduction, and it's my pleasure to be here today on behalf of the National Psoriasis Foundation. And you also mentioned that the Corona Registry, it's kind of an unfortunate name, but remember that was with two R's. I'm also one of the clinical researchers for the Corona Registry, and we have many patients participating in that. And I also thank the sponsors for putting on this forum for patients with psoriasis and psoriasis conditions, including psoriatic arthritis. There are several categories to the questions that we have that I hope to answer for you today. And they're listed here as compared to other forms of arthritis. Where does psoriatic arthritis fit in? What are some of the symptoms that we see with psoriatic arthritis? And when I say the word arthritis, it's like with any condition that ends with itis, that means inflammation. And when we're talking about arthritis, it's inflammation of the joints. But as I'll mention, that there are other symptoms associated with psoriatic disease, in that the tendons where they insert into the bone may be affected, a condition called enthesitis. Again, the enthesis, where the tendon inserts into the bone, and then something called dactylitis, which is a whole finger or toe that gets swollen, and it's more than just the joint, so the soft tissue is involved. Then some of the treatments and the categories of treatments that we have access to, and other medical care, including some of the associated conditions that we see with psoriatic arthritis and psoriasis. So that is my hope, to be able to discuss some of these questions with you, and then open it up and hopefully have some other questions that will be may be added. So let's just talk about the forms of arthritis. And so the question is, one of the questions, how do you know if you have psoriatic arthritis or some other form of arthritis? And so it's an important question, because obviously the treatments for the different types of arthritis are different. There may be some commonalities amongst the different treatments, but for many, they don't realize that there are over 100 different types of arthritis or rheumatic illnesses. And so making the definitive diagnosis of psoriatic arthritis is critical, so that the patient, the practitioner, can be on the same page as far as what they're talking about in regard to getting to control of the condition of the psoriatic arthritis. So what are some of the common things that are seen in the very common types of arthritis? Well, we know that the most common form of arthritis is called osteoarthritis, and that has other names associated with it. And some people have heard the term degenerative joint disease. I don't like that, because it makes me think that I'm getting more mature or older. I like the word maturity as opposed to getting old or being elderly. But as we do mature, the cartilage wears out on the covering at the ends of the bones. And that's classic for osteoarthritis, typically seen as a non-inflammatory form of arthritis. But that's the most common type. I'll come back to that in a second. Then there's rheumatoid arthritis, and I think psoriatic arthritis is frequently not distinguished from, and that's the problem, because you really want to know what the definitive diagnosis is. But there are ways of knowing if someone has psoriatic arthritis versus rheumatoid arthritis. One of the criteria for having psoriatic arthritis is that the tests for rheumatoid arthritis are negative, in particular the rheumatoid factor. So that would be easy if all patients with rheumatoid arthritis had a positive rheumatoid factor, but in fact only about 75 to 80% of patients with RA or rheumatoid arthritis have a positive rheumatoid factor. But if you have psoriatic arthritis, you typically don't have a positive rheumatoid factor, or another antibody that's seen in rheumatoid arthritis called the CCP antibody. So if you have psoriasis, then you're much more likely to get psoriatic arthritis. And in fact, about 30% of patients that have psoriasis will develop psoriatic arthritis. At some time during the course of their condition, psoriasis typically develops first, and it may take 8 or 10 years before people then develop the symptoms of psoriatic arthritis. So obviously having psoriasis would predispose someone to getting psoriatic arthritis, and that's an important historical note. Now, some patients that have psoriasis don't have psoriasis that covers their body. They only have maybe some small patches of psoriasis, or other areas of the body are involved. I mentioned just a moment ago about where the tendons insert into the bones, and in particular, like at the elbows, where some people are thought to have tennis elbow or golfer's elbow, whether it's the inner or outer aspect of the elbow where the tendons insert into the bones, and they may have just been told they have tennis elbow or golfer's elbow tendonitis, and the healthcare professional that's taking care of them doesn't realize that they have psoriasis, or that they don't make the connection that that actually may be enthesitis. Other common areas where you can get enthesitis are in the inner or outer aspects at the knee. And then another common site would be at the Achilles tendon. So if someone has unexplained tendonitis and they've had psoriasis, even if they don't have arthritis yet, where the joint is involved, they're likely having symptoms associated with psoriatic arthritis. I also mentioned dactylitis. That's a very classic finding in psoriatic arthritis, where the whole digit, like the finger or a toe, unexpectedly and without other reason, like for example, there hadn't been any trauma to that particular finger or toe, and it gets hot, red, swollen, painful, the classic features of inflammation. If you remember your Latin rubor, dolor, color, heat, redness, pain, and swelling are all associated with inflammation, and dactylitis is kind of one of the hallmark features of psoriatic arthritis if you get that. Of course, not everyone gets dactylitis. Psoriatic arthritis may be actually one of the first things that happens, and patients get their arthritis first and then later develop psoriasis. That's much less common, but much more frequently, patients have a long-standing history of psoriasis, have a family history of psoriasis or psoriatic arthritis, and that is very helpful in distinguishing whether or not somebody has psoriatic arthritis versus other common forms or even less common forms of arthritis. The second question really gets to part of what I discussed, what test is done to determine what type of arthritis you have. Well, I mentioned the rheumatoid factor and the CCP, or the cyclic citrulated peptide, a kind of a long name for a very specific test for rheumatoid arthritis. There is no specific test for psoriatic arthritis. So it's really one of the criteria, the classification criteria for psoriatic arthritis has to do with the lack of a blood test, as I mentioned a moment ago, the rheumatoid factor, or CCP, really. There are other forms of arthritis, and I didn't mention ankylosing spondylitis yet, but ankylosing spondylitis is a form of arthritis that affects the spine. Typically, the buttock first, the sacroiliac joints are also involved classically in ankylosing spondylitis. With that particular condition, it affects younger people, typically under 40 initially, but obviously patients have this condition for a lifetime. So I have patients that are in their 70s or 80s that have had AS for a long time. There is another blood test associated with that, and is seen in about 90% of patients that have ankylosing spondylitis, and that's called the HLA-B27 gene. It's a gene test. So that is a gene that predisposes patients, which is familial, to having ankylosing spondylitis. Interestingly enough, there are patients that have psoriatic arthritis that also have involvement of the spine and may be HLA-B27 positive. That said, just by having that gene does not necessarily mean you either have ankylosing spondylitis or psoriatic arthritis, but it clearly predisposes you. And in fact, about 7 to 8% of the the general Caucasian population has that gene and never gets arthritis. So it's not a definitive requirement or something that will absolutely lead to arthritis. Another not that common form of arthritis, but you may certainly have heard of the condition called systemic lupus. It also has rashes associated with it, not psoriasis, plaque psoriasis or other types of psoriasis, but a rash that is over the cheeks of the face, or that a rash that may occur when patients go out in the sun called a photosensitive rash, has another blood test associated with that particular form of arthritis that can be seen in patients with systemic lupus, and that's called the ANA test, or the anti-nuclear antibody test. And that's a very commonly found test in patients that have lupus. In fact, about 96% of people that have lupus have that condition. Then there's a variety of other conditions. Remember, I said there's over 100 different types of rheumatic illnesses that can be associated with arthritis that are less frequently seen. Conditions like Sjogren's syndrome that have both ANA tests and other antibody tests associated with it, Sjogren's antibodies in particular. So that may be some of the blood tests that can be associated with trying to determine which type of arthritis one may have. Next question on this forms of arthritis is, lately my pinky, when I wake up, is folded into my hand. Is this from my arthritis? It takes a while before I have use of it, and it's painful. And so I have many patients where their pinky gets involved. Similarly, it may be the pinky of the toe. But when the pinky is folded, or the fifth finger is folded into the hand, it may, number one, yes, may be due to arthritis, but it also may be due to tendinitis and something called tenosynovitis, or inflammation of the lining of the tendon, tenosynovitis. And so this can be seen both in psoriatic arthritis and is commonly seen in rheumatoid arthritis. There are other reasons, though, that the pinky can get folded into the hand, and if it's something that you can kind of pop out, and that does occur with that kind of popping sensation or kind of a clicking sensation, you may have a trigger finger. And oftentimes that may be caused by a little nodule, typically a benign nodule, that forms on the palm surface of the tendon and may have your finger kind of curl up, and then when you try to pop it out, it hurts when it kind of snaps open. That's called a trigger finger. And that may be associated with psoriatic arthritis, with rheumatoid arthritis, or just you might have a trigger finger. Lastly, when you talk about the pinky, there is another condition that's typically seen in patients from Northern European descent, where there can be a contracture or a kind of a closing down of the fingers, where they're forced to flex, typically the fourth and fifth fingers. But that's something that's over time, doesn't just happen overnight. And it's a condition, and some of you may have heard of this, called Dupuytren's contracture. And I typically see this in patients of English or Scottish or Northern European descent. In fact, I just had a patient yesterday say that she has had that problem for some time. She came with her daughter, and the daughter said, gee, I'm getting kind of the same thing, and it can be a hereditary issue. It's not a form of arthritis. It's really a tendon-related problem, and there's treatments for that too. So my hope is that this addresses some of the features of the forms of arthritis. I'll now move on to some of the symptoms, and the question here is, can I address the different symptoms of psoriatic arthritis flare? I've talked about some of this already. Typically, when the joints get hot, red, swollen, and painful, that clearly is an issue with an arthritis flare. But also, please remember that it may not be, even though it's psoriatic arthritis, it may not just be in the joint. There may be, as I just mentioned a moment ago, for those of you that may have the arthritis associated with psoriasis in the spine or in the buttock area, like at the sacroiliac joints, that may be that may be sore, and especially in the morning. Morning stiffness and pain is typically associated with this kind of inflammatory arthritis, but there also may be symptoms around the tendon areas, the entheses that I mentioned a few moments ago. Similarly, with the dactylitis, the whole finger may get swollen, may get red, may be painful. See, these are some of the symptoms associated with psoriatic arthritis. One thing I can note is that oftentimes when people have a lot of stress or they're not exposed to the sun and their psoriasis flares, this may predispose people to getting a flare of psoriatic arthritis. The next question here is, why do I always have bad days after about a 30-minute or more car ride? It's not just a car ride. I mean, I had a patient this morning, a new patient to me, that says, I sit at a desk all day, and when I try to get up, if I've been sitting for more than an hour or two, I am really stiff, and I'm sore, and the rest of the day isn't good after that. My suggestion to patients like that is, as there's kind of a gelling effect, and if you think of Jell-O, how that kind of is a gelling effect, can happen in the joints, and that's why most patients that have active psoriatic arthritis, this pertains to rheumatoid arthritis too, but for psoriatic arthritis, can have that worse symptoms in the morning. Even though you'd think after sleeping all night you'd do better, a lot of patients that aren't sufficiently treated have that gelling effect. And similarly, after a car ride where you're seated in one position for 30 minutes or more. The next question here is, I keep hearing information about fibromyalgia and psoriatic arthritis, and that you can have both, and what distinguishes one from the other. It's difficult to know when you're in pain and feel tired all the time, and that's true. It is hard when you're in pain and really you're fatigued all the time. But psoriatic arthritis, again, is an arthritis. There's inflammation of the joint, as I mentioned, the entheses and dactylitis. Fibromyalgia is a chronic pain syndrome. It's a real syndrome. It affects women more than men, and typically they don't have the common features that are seen in psoriatic arthritis. For example, the joints are not swollen or painful. There are multiple areas around a person that has fibromyalgia that has tender points. It's really a chronic pain syndrome, and there are specific treatments for fibromyalgia. The blood tests are typically normal. Certainly there's no HLA-B27 associated with that as compared to those that have the spine involvement with psoriatic arthritis. Rheumatoid factors and whatnot are always negative. Anti-nuclear antibodies are not significantly elevated. And in fact, all of the blood tests for fibromyalgia are typically normal. And so that's helpful in distinguishing it. And then whether or not, and it's typically associated with a sleep disorder. Patients even sleep 8, 9, 10 hours. They wake up, they feel worse than when they went to bed. So it can be a combined condition with psoriatic arthritis, but that really, you need to be with someone that has had experience in diagnosing both conditions, typically a rheumatologist or a physician assistant or a nurse practitioner that has extensive experience in seeing patients with rheumatoid arthritis, psoriatic arthritis, and rheumatic diseases. Next question is, what symptoms of psoriatic arthritis still present while taking a biologic DMARD would justify changing to another biologic with a normal C-reactive protein and erythrocyte sedimentation rate? So symptoms of psoriatic arthritis that are still present while taking a biologic, and remember these are either injectable medicines, the class of anti-TNF therapies, there's the class of IL-17 inhibitors, there's the class of T-cell inhibitors, and then the smaller molecules that have been, which are pills that have been approved now for psoriatic arthritis. What would be the symptoms that would require, or where I would recommend changing therapy? The fact that someone has a normal C-reactive protein or sedimentation rate, both indicators of inflammation in the bloodstream, are important, but not essential for me to make that decision. What would make the decision? And for every patient I see that has psoriatic arthritis, and I do this for rheumatoid arthritis too, every patient, every visit, I do an assessment of what their disease activity is that day. And there's a combination of things that are looked at when looking for or how to measure the disease activity. And there's something called the DAPSA score, the disease activity and psoriatic arthritis score, where it's a measurement of tender and swollen joints, and then what the patient says, how severe their disease is, and what the clinician says what the disease activity is. And if somebody is in moderate or high disease activity, despite having a normal C-reactive protein, or SED rate for that matter, that may be an indication if it's been 2 consecutive visits, 3 months apart typically from my patients, then it's time to consider changing more advanced therapy, like with a biologic disease-modifying therapy. The next question is, I've been almost cured, but it came back in the previous condition. What does this mean? So I would love to know that you were cured. I don't know of any cure quite yet of any for psoriasis or psoriatic arthritis, but the treatments that are available now for these conditions are so incredibly more effective than they were when I first started my training at LA County USC in 1980. But for those that don't know me on the call, actually the first person that I saw with psoriatic arthritis was in 1964. And you may not know how old I am because you can't see me, but I was 12 in 1964, and my dad was a rheumatologist, and I used to see patients with him. And the treatments that he had available to him to treat his patients were basically the same treatments I had available to me in 1980 as an intern at LA County General Hospital in Los Angeles. And then still the same when I went on the faculty at USC to run the inflammatory arthritis clinic in 1985, where we were still using tried and true medicines. I mean, we learned about methotrexate from the dermatologist where they were using it for psoriasis, and we were using it for psoriatic arthritis in the 60s, 70s, and 80s. But we were even trying gold injections. And for some of you may remember that, but I ran the gold clinic at LA County General Hospital in 1986. Those medicines, aside from methotrexate, have long been dispelled and are no longer in use now that we have access to much more effective therapies. And so maybe you're on one of those medicines that you felt as though you were cured, but sometimes the medicines don't hold, and sometimes they need to be changed, or oftentimes there may be a change in anxiety or just other things that can affect someone's immune system, and being anxious or having traumas that happen, like for example with this whole COVID-19 issue. I mean, a lot of people got anxious and had flares of their psoriasis and psoriatic arthritis, and it may be associated with that. But because of the number of therapies that are available, there are just dramatic therapies that can be changed to get you back to feeling as though you're cured again. The next question is, I have spontaneous flare-ups, latest on your left wrist, for which I've received a steroid injection. What causes the flare-ups? It's really the immune system. To start, I can tell you that they don't know, number one, what causes psoriasis, what causes psoriatic arthritis. What we do know triggers, and some of the triggers are missing medicine, sometimes lack of effectiveness of medicine, sometimes, and I mentioned this, anxiety or other stressors that affect patients. And oftentimes, I mean, even I have patients come to see me and said, well, this is what's happened, and we really didn't know what caused my flare, but a relative passed away or some other major stress, or just look at what's happened again, taking the COVID-19 disaster in regard to businesses and whatnot, that can cause a flare-up. And I think the immune system and our ability to cope with that is responsible for many of these flares. The next question is, how do I know if my joint pain has progressed to permanent joint damage? Well, as Bev mentioned earlier, one of my main interests over the past 2 decades has been in advanced imaging in assessing patients with inflammatory arthritis like psoriatic arthritis. And typically, your clinician may ask you to get x-rays, conventional radiography, to assess how your joints are doing, whether it be the hands or wrists or feet or whatever joint may be involved, like a hot swollen knee that I saw in my new patient today. And so x-rays can be helpful. They're 2-dimensional, so it doesn't give all of the answer. And in particular, it doesn't give the answers about some of the soft tissues that are involved, for example, around the knee, like the entheses or the elbows, or if someone has dactylitis around the toes or fingers. So more advanced imaging like ultrasound or MRI may be the way to go. and especially early on. And so if you feel that you have psoriatic arthritis or you've just recently been diagnosed and x-rays are normal, it doesn't necessarily mean that there isn't damage already going on and that may be progressing. And so my recommendation to you would be to encourage your clinician to consider either ultrasound or MRI, which has been well documented to determine changes before permanent damage occurs. And clearly, by the time it does occur, it may be evidenced by regular x-rays. So I think that went to the symptoms. I'll go now on to the treatments. What are the parameters for changing therapy? Again, I mentioned the DAPSA score or disease activity score. If someone's in moderate or high disease activity, then that would be a parameter for changing therapy. Obviously, if the patient says this is not working, despite what the score may be, the clinician, the rheumatologist, nurse practitioner, PA, whoever's treating the patient, has to hear the patient. I mentioned my dad a moment ago and that I'd seen his patients when he was in practice, when he was still with us years ago. He taught me two very important things. One of them was listen to your patients. They're usually right. Boy, that took me a long time to learn, but I think he was right in that regard. The other thing I'll just briefly mention, he said, try not to tell your patients what to do because some of your patients may actually like you and they may shake their head yes in the office and walk out shaking their head no because I didn't listen to them. So some other hints maybe to share with your clinicians. But anyway, the parameters for change are being in moderate or severe disease activity, not responding to treatment, certainly by 6 months and oftentimes by 3 months if there's been absolutely no change. Next question is, can low-dose prednisone, 5 milligrams a day, help reduce damage from psoriatic arthritis? And the anti-inflammatories and prednisones, corticosteroids have been around since the 1940s, can help to reduce inflammation. By reducing inflammation, it may help to reduce damage. That is a controversial issue in patients with rheumatoid arthritis and even in psoriatic arthritis. My preference is not to have patients on prolonged corticosteroids, even 5 milligrams a day. The lower the dose, the less likely to have potential side effects from long-term corticosteroid or prednisone use. But my problem with prednisone is that it works. It works really well. And 5 milligrams sometimes leads to 6 or 7 or 8 or 10. And when you stop prednisone, when you have psoriasis and psoriatic arthritis, the psoriasis typically flares terribly. So the question would be, if that's the only thing that's working, typically along with another disease-modifying therapy, the data is mixed on it being able to help to reduce damage. But if it helps to reduce inflammation, my answer to that would be yes. What's my position on turmeric? Taking 2 500 milligrams capsules per day, is that a reasonable dose? Is 4,000 a day dangerous? So turmeric is a over-the-counter supplement. There has been data that shows anti-inflammatory supplements can be helpful, at least for rheumatoid arthritis. I have not seen the data on psoriatic arthritis, but if it does help to reduce the inflammation, 500 milligrams twice a day is a reasonable dose. There have been some studies that suggest that there's a black pepper that goes along in that turmeric that may help get it absorbed. I don't know any data on 4,000 milligrams a day, but 1,000 milligrams a day seems to be a good anti-inflammatory dose in patients with rheumatoid arthritis. So if that is working for you, I don't see any downside. Next question is, what biologics are best for psoriatic arthritis? They all are great. I have to tell you, and it depends on the individual. So we do a lot of clinical research here in my office. So I studied most of the biologics for psoriatic arthritis as well as rheumatoid arthritis. And it really is patient dependent. So not just biologics, but now the small molecules, what are called the JAK, J-A-K, or Janus kinase inhibitors are also available. And it depends on how you respond. So it may be a trial and error. What's the best treatments for managing pain? And that encompasses, number one, in my opinion, if it's not pain due to end-stage, what I call end-stage joint disease, meaning there's virtually no joint left, and that joint may need to be replaced, that may be the best treatment for that patient. If it's earlier in the disease course, whatever helps to decrease the inflammation typically helps manage the pain. That may be a combination of pure analgesics like acetaminophen or stronger pain medicines, anti-inflammatory medicines, the disease-modifying therapies, and if there's a portion of the pain that may be due to fibromyalgia, medicines that can help control that. I also should mention that other conservative therapies like physical therapy, occupational therapy, heat, cold treatments may also be very helpful. It doesn't have to be all medicine. There may also be some of the anti-inflammatory therapies like I mentioned turmeric or even high-dose fish oil may help in reducing inflammation. Next question is, do I use any of the newer therapies, IL-17A or IL-23 to treat psoriatic arthritis? And I do, and I've used many of these medicines. There's also an IL-12, 23. The IL-23s by themselves are currently approved just for psoriasis. I think ultimately they will be approved for psoriatic arthritis, but the interleukin 17A inhibitors, yes, I do, and have found them to be very effective. Next question is, I get fatigue from methotrexate. What can I do to stop the fatigue? Should I change my treatment? So methotrexate is, once again, a tried and true medication. It's been around for decades. Very helpful, typically, in the appropriate patient that responds to methotrexate. And as long as they're being monitored, I typically monitor with blood tests every 3 months my patients taking methotrexate, looking for changes in the blood count, changes in the liver enzymes or the kidneys and whatnot. And so fatigue is one of the common symptoms associated with methotrexate. And folic acid should always be given with methotrexate because it helps to decrease some of the potential side effects, one of them being fatigue. So typically the methotrexate dose may vary anywhere from maybe if you're taking pills, 6 pills, 8, 10 pills, even more sometimes, ranging 15, 25 milligrams a week. Folic acid is typically taken daily. Some people don't take it on the day they take the methotrexate. But the folic acid dose can actually be increased, not just at 1 milligram, but actually up to 5 milligrams a day. But the higher the dose, the more it may impact the effectiveness of the methotrexate, especially when you get over 5 milligrams a day. One of the things you can do is to try to decrease the fatigue is ask your practitioner to help, if it's okay with them and you, to increase the folic acid to 2, 3, 4, even up to 5 milligrams a day. That may help the fatigue. If it doesn't, should you change treatment? Well, if the fatigue is disabling, then yes, I would consider changing therapy. Next, again about methotrexate, does methotrexate stop joint damage or is that only by using biologics? No, methotrexate has been shown to decrease joint damage by decreasing the inflammation. And, depending on the patient population, it can. In rheumatoid arthritis, for example, it works in about a third of the patients. Just for the joints in psoriasis, psoriatic arthritis, it can help both the skin and the joints. But if it doesn't work, or if it doesn't work well enough, then more advanced therapy should be used. And the next is on medical care. And what's the best type of doctor for overall care? I get passed around because of the lack of understanding about flare-ups. So I encourage all of my patients to have a primary care provider, whether it be a family medicine doctor, internal medicine doctor, nurse practitioner, physician assistant that works with one of these types of doctors. I think you should have. But the best person to manage your psoriatic arthritis, in my opinion, would be a rheumatologist. I always work with a dermatologist that is very familiar and likes to treat patients with medical skin problems like psoriasis. And I have a very good working relationship with several dermatologists in my community. So I would recommend having a primary care doctor and then having a rheumatologist and a dermatologist. And do I think telehealth is here to stay? Very interesting and important question. I'm the faculty for a great rheumatology national meeting, international meeting that's held every February in Maui because somebody's got to go to that. So I volunteered. Actually, I'm on the faculty for that meeting called the Rheumatology Winter Clinical Symposium for the past decade. And I was in a debate with one of my colleagues and friends from Wisconsin about whether or not physicians and healthcare providers should be using telehealth now. And that was in the first week of February of this year. I was given the position of being against. I was in a debate and I was given the against side, so I had to come up with reasons why I didn't think it was a good idea, even though I think it is a good idea. And look at what's happened. I mean, just in my personal practice, within 48 hours of everything being shut down the third week of March, we were up and running with Zoom, FaceTime, and Doximity, and ways that I could still interact with my patients. And although my patient volume was cut in half for the first week or two, that continued to progress and get more and more busy to where I'm now back to my usual schedule. But in the beginning, it was 75% telehealth, telerheumatology. And now it's about 50%. And I guarantee you, if you live anywhere in the Los Angeles area and you don't have to come drive to see me when the traffic gets back to normal, you're going to want to do this kind of visit. And so it's appropriate for probably interim visits. And I do think it's here to stay. And I think this is going to change. And this whole COVID-19 virus epidemic and pandemic has changed things probably for good. I have patients that come to see me from other states and clearly from 3 or 4 hours away that would prefer just to do a telehealth visit. And that's appropriate. If you have a hot swollen knee, I can't aspirate and inject your knee, so you'd have to come in for that. But yes, I do think it's here to stay. Obviously, the Medicare and private insurers are going to have to reimburse for that to make it worth the physicians and the healthcare providers worth their while to continue to do that. But right now, that is on board, and I think that's just a financial issue. But I think from a patient standpoint, I'm having very, very good interactions doing telerheumatology, telehealth. And so that was my last question I had, Bev. I don't know, is there another question that may have come up, or do you want me to answer anything else?
Yes, I do have a couple other questions for you.
Okay.
The first is, what are the main side effects of TNF inhibitors such as Enbrel?
So the main potential side effect of the biologic therapies or TNF inhibitors are an increased risk of an infection. Enbrel and the other TNF inhibitors don't give you infections, but they lower your immune system, which is exactly what we're trying to do, because patients that have psoriasis and psoriatic arthritis have an increased overactive immune system, but in a bad way. It's causing psoriasis, it's causing arthritis. So we're trying to lower that and try to get that person's body and their immune system at a normal level. But with that comes the potential that there may be an overshoot of lowering the immune system. And the most likely side effect is an infection, typically an upper respiratory tract infection. Most of those are colds and sinusitis and things like that, but other much more serious infections can occur, including pneumonia. There are other potential side effects, but infection is my biggest issue for more advanced therapy.
Okay, the other question is, my dermatologist is suggesting I go on Taltz because I have psoriasis and arthritis. He's wondering, does that mean by suggesting he goes on Taltz, does he automatically have psoriatic arthritis?
So Taltz is one of the interleukin 17A inhibitors and very effective for psoriasis and psoriatic arthritis. So it doesn't automatically mean that that person has psoriatic arthritis, because they may just be treating the psoriasis, and it's very effective for that. But the question would be, if there are symptoms that I had mentioned in my discussion, I would ask if the dermatologist is not comfortable evaluating that person for the potential for psoriatic arthritis, that there be at least an initial rheumatology evaluation, and then both conditions, both psoriatic arthritis and psoriasis, can be followed.
Thank you, Dr. Troum, for your time and expertise today. We appreciate you taking time to answer the questions about the symptoms, diagnosis, and treatment of psoriatic arthritis.
Thank you, Bev. Thanks very much for everyone that listened in. And I hope we all get through this virus COVID-19 time together. And please be in touch with the folks that Bev spoke about in regards to the National Psoriasis Foundation, and any further information you may need, I'm sure we can answer for you.
Thanks again, Dr. Troum. So May is Psoriatic Arthritis Action Month. You can continue to learn more about psoriatic arthritis from screening to treatment options. Learn more about screening for psoriatic arthritis by taking a short screening test. Request a free PSA e-kit, which includes information about mobility, stretches for psoriatic arthritis, and tips for being physically active with psoriatic arthritis. Access the activities by visiting psoriasis.org/PSA-action-month. You can also help support the NPF's research efforts to identify a diagnostic test for psoriatic arthritis. The NPF is currently funding 6 psoriatic arthritis diagnostic test grants. With this tool, our hope is to prevent the development of long-term joint damage. In addition to today's webinar, podcasts are also available through Apple Podcasts, Google Play, Spotify, iHeartRadio, or a feed service of your choice. You can access podcasts at the website listed here. If you'd like more information about psoriatic arthritis, catch our podcasts about fatigue, musculoskeletal symptoms, and diagnosing psoriatic arthritis at psoriasis.org/podcast. Contact the Patient Navigation Center if you still have questions, would like additional information about treatment options, need help finding a physician, or are having issues with accessing treatment. You can contact our Patient Navigation Center by phone, email, or live chat as indicated on the screen. You can also contact the Patient Navigation Center to ask about the mobility, stretches, and exercise quick guides mentioned earlier. Once you leave today's webinar, you'll receive a survey to provide feedback about the presentation. Tell us what you think. We value and appreciate your comment. I'd like to extend a sincere thank you to our sponsors, AbbVie, Amgen, Bristol Myers Squibb, Lilly, Novartis, and Pfizer for their support of today's webinar. And finally, you can access our webcast archive at psoriasis.org/webcast. This concludes our presentation for today. Thank you for attending.